That's about a minute after the hour. Why don't we go ahead and get started? So, good morning, everyone. I'm David Mohr, and I'm president of the Society for Digital Mental Health, and I'm delighted to welcome you to our society's second annual conference. I think all of us here recognize that the American mental health care system is fragmented, and it doesn't serve the people. It doesn't serve most of the people who need help. And I think we also all recognize that digital mental health has an enormous opportunity to solve many of the problems facing our mental health care system. So research has consistently demonstrated that digital mental health is effective, particularly for common mental health problems like depression, anxiety, PTSD. However, our ability or attempts to implement these in healthcare, these digital mental health services in healthcare systems, in sustainably and effectively, those kinds of implementations have been few and far between. So the policy, the business models, the implementation methods are all still evolving. So the goal of the Society for Digital Mental Health is to bring together all stakeholders from research, from industry, from healthcare, payers, people with lived experience, to learn from one another and to overcome the challenges and to ensure that all people in the United States with mental health problems have access to digital mental health. And hence the theme of this conference, bringing together academia, industry, and healthcare collaboratively to advance digital mental health. So bear with me here while I share just a few slides. So first of all, I want to recognize the board of directors. In addition to myself, Stephen Schulers, the secretary, Adam Powell, the treasurer, Zabina Wilhelm, our membership committee leader. Special call out to Bethany Teachman, our program chair, Cesar Escobar Vieira, communications chair, and our student representative, Emma Wolf, and assistant for communications, Sarah Hill. And then a huge shout out to the conference planning committee. Bethany, in addition to Bethany, Margaret Anton, Alexandra Silverman, Shirley Wang, Hillary Weingarten, and Vail Wright. A special shout out to Adam Goodkind, our accessibility coordinator, and Jeremy Eberle, our open science coordinator. And I want to thank everyone who supported the Zoom events meetings. It was a huge lift. And all the people who are on the call, on the conference right now, who will be serving as moderators over the next 2 days. I want to briefly go through our program. I'll be introducing our keynote speaker in a moment. There are 2 panels. So today, integrating digital mental health into healthcare systems, and tomorrow, making digital mental health work for marginalized communities. And then, like last year, we have poster sessions and flash talks where there should be ample time for questions. Last year, first of all, thank you all who answered the post-conference survey last year, and we did pay close attention to it. So in addition to wanting to keep it virtual, there was a lot of feedback that people wanted more opportunities for conversation, for interaction, for discussion, for networking. And so our program committee has been extremely creative in creating opportunities for those. So at 2 o'clock today, and then tomorrow as well, there are Ask Me Anything sessions. And so these are experts who are available for questions. These are intended to be very, very conversational. There's not a presentation in these. It's an opportunity for you to interact with these experts, and as well as with each other around those topics. And then tomorrow at 2:05, there's Challenges Faced and Lessons Learned, which cover a range of hot topics where we're all experiencing challenge. And again, there might be a brief, some of those might have a very, very short introductory slides, but they're intended to be very, very conversational. So we have really tried to make this meeting far more interactive and engaging. I also just want to mention this evening at 7 Eastern time, there's the Digital Mental Health Clinical Psychology PhD program open house, if you're interested. And then on Thursday from 1 to 2 Eastern, the Graduate Student Career Panel Coffee Hour. So if you're interested in those, please attend. Also, a quick thank you for our founding sponsors, the Bowman Family Foundation and Brain Futures, and our corporate roundtable members who have generously funded our society and this meeting, Boehringer Ingelheim and Otsuka Pharmaceuticals. If you are on social media, please use the hashtag SDMH2023. And I want to, again, encourage you to attend the conference, attend the interactive sessions, engage, learn from each other. And now I would like to introduce our keynote speaker, Cynthia Castro Sweet. So Cynthia is the senior director for clinical research at Modern Health. And she received her PhD in clinical psychology with a specialization in behavioral medicine from the University of California, San Diego, and the San Diego State University joint doctoral program. She was in academic research at the Stanford Prevention Research Center for a number of years until 2015, when she left Stanford and went to Amada Health, serving as the senior director for clinical research and policy. A little over 2 years ago, she left that position for Modern Health as the senior director of clinical research. And so, you can see Cynthia's career trajectory goes from academics and healthcare and industry, covering a broad number of areas, making her, I think, the perfect keynote speaker for this year's annual conference. So she'll be speaking for about 30 minutes, and then we'll have about 5 to 7 minutes or so of questions. If you have questions, please put them in the Q&A, not in the chat, but in the Q&A function, and we'll get to as many as we can. Cynthia, it is a real pleasure to have you here. Welcome.
Thank you. Thank you, David. And thanks everyone for attending this morning. And I'm quite flattered and honored to be invited to give the opening address for this meeting. And I'm really excited to see how the conversations are going to go over the next 2 days. So why don't we get into it? Thanks for that generous introduction. So I don't need to, reiterate who I am or where I'm from, but I will mention my disclosures as I work for a company in the private sector. So while I am employed by Modern Health, my company did not have any input into what I'm going to talk to you about today, although in hindsight, I'm betting they will probably wish that they did, but they did not. So just for the record, all the ideas, the thoughts you're going to hear from me today are my own, and we have no one to blame but me and the organizers for inviting me today. So I thought, I would start. I'm not sure how many of you know me or have interacted with me or met me before. I have been around for a while, but there's probably a lot of people in the audience who don't know who I am and might be wondering, why am I here giving the keynote? And I think, as David said, I'm probably here in front of you today because I'm one of the few people who spent quite a lot of time in the academic sector and in the private sector, spent quite a number of years in both settings. And I'm going to start kind of telling a little bit more detail about how I spent my time working in digital health as a psychologist and how that's really shaped my perspective on where we are in this field today. So this is a little bit of a repeat of some of the notes that David mentioned about my past, but here's how I got here in front of you today. I also want to make mention that I am a licensed clinical psychologist. I was trained in a pretty solid traditional scientist practitioner PhD program in San Diego. Then I did my internship at the Palo Alto VA system. And this is, I think, kind of where some of the original nuggets of my thoughts on healthcare started. As a psychologist in the VA, I got to work and train in a lot of different settings. I was embedded in the primary care clinic. I think the VA is pretty progressive in some ways, and was one of the first settings that really tried to integrate behavioral health into primary care. So I got to experience working in that setting and working alongside primary care physicians. I also went out into people's homes and worked with home-based primary care. So again, working with the medical teams and being the psychologist, literally driving VA vehicles around the Bay Area to visit veterans in their homes and deliver behavioral health where they lived. And, it's a very eye-opening experience to understand the environment and the social context where people are living and how that relates to their presenting conditions. And I also worked in kind of some traditional settings like inpatient psychiatry and the behavioral medicine specialty clinic. And some of my recollections of that time in training is when my supervisors pointed out to me that even though, we had a pretty full schedule of patients to see, and our schedules were pretty booked, and there were waiting lists, they reminded me that a very small percent of veterans actually use the VA system to get their health care. And on top of that, an even smaller percent ever managed to get in front of a psychologist. And those same supervisors told me that that experience is not unique to the VA. If you want to work in any healthcare setting, even though your schedule will be booked and you'll see that, you're seeing a lot of people for psychotherapy, you're really only ever going to encounter a very small fraction of them. And think about all of the other people out there in the ecosystem who may never get in front of a psychologist. And I think that was kind of had a profound impact on me and my views about how we're offering healthcare and some of the challenges that we experience. And it's easy to get caught up in the patients that are with you in the room and lose sight of all the others that we may never see and may never make it into that clinical space. So after my clinical training, I went the route of being an applied clinical researcher. So I spent many, many years at Stanford doing applied health behavior research, ran a lot of clinical trials, trying to prove that there are different behavioral interventions that are effective, what kinds of programs work in what kinds of settings for different populations, a lot of that kind of primary discovery of, what kinds of interventions are working for people. And of course, being in Silicon Valley, we were always trying to figure out how to use emerging technology to deliver interventions, to be able to reach more people more seamlessly with less friction points using technology to try to be a faster and more accessible delivery vehicle for our interventions. And I don't know if it was just the nature of my research or being at Stanford, in the heart of Silicon Valley, I had a really interesting vantage point seeing the rise of startup tech companies in Silicon Valley. So I was there at Stanford during the dot-com boom and the subsequent bust. I was also there during the digital tech boom that emerged in the 2010s. And then I started to see the healthcare startups arrive. I would say, from my perspective, it felt like the healthcare startups came a bit later. Teladoc and WellDoc were some of the early ones. I think Teladoc was founded around 2000, 2002. But Rock Health, which is a huge venture capital firm that really heavily invests in digital health, it's a big investor and supporter of digital health startups. It didn't launch until 2010. So, the tech world was really making strides, and big tech companies, and then healthcare started to catch on, and this concept of, healthcare startups really started to emerge. And I got caught up in that wave. I did leave academia in 2015, and I joined Omada Health, which at the time was kind of a little bit of the golden child of digital health. And it was a really terrific opportunity. And I felt really fortunate to work for that company. And while I was there, our company was successful in working with the CDC to develop guidelines for digital programs to become recognized DPP providers. So really to engage with a government agency as a startup, that's something I didn't do a lot in academia. But to be able to do that in a health startup was really eye-opening. And having that connection and having that recognition program expand to digital programs was really instrumental to get the attention of healthcare payers. And the company was also successful in getting a new reimbursement code for electronic or online delivery of the DPP. Okay, and again, that's something I never would have considered doing in academia. But these startups are really, at the forefront pushing for these kinds of things. So I stayed at Omada for 5 years, which is a really long time in healthcare startup culture. And then a couple of years ago, I decided to go back to my roots in psychology, and I joined a startup called Modern Health. We have a comprehensive mental health platform. So I joined to lead the research team there. And if you really want to get a sense of kind of like my career and what we've seen in terms of technology over the years, when I started my career, we only had 2G, y'all. We had very primitive cell phone technology. Nokia was one of the big leaders in the cell phone market. back then you could not text outside of your own network. That's how kind of ancient I am and the technology was back then. The iPhone was introduced about midway through my span with Stanford. When I joined Omada, that's when the Apple Watch came out. And now, no surprise, all we seem to want to talk about is Chat GPT and AI when we talk about, the merge of technology into healthcare and what it can do and what some of the opportunities and danger zones might be. So I go over my career span. I talk about it, quite a bit with different groups because, I've been in this field for quite a while. And while I've seen technology change over the course of my career and my life, and I've seen some amazing things in the field of digital healthcare for chronic conditions, the field of mental health, I think, has not progressed at the same rate. And I think David alluded to that too in his opening notes. And I think in recent years, especially since the pandemic, we have made more rapid progress and have accelerated conversations about mental health. I think we've been making strides in at least how we're talking about it and talking about how we can tackle stigma, helping people grasp the notion of mental health as being distinct from the concept of mental illness. We're normalizing help seeking. I think all of that has been great. I think the conversation has really shifted and has become more inclusive. And I think that's really been important. But clearly, there's a lot more room to make for progress. Still a third of our population does not have easy access to a mental health provider. And we are decades away, In my lifetime, we will probably not close the supply gap of mental health providers. And we see huge disparities in where the providers are located and where the shortage areas exist. And the irony is that what we don't have is a shortage of treatments that are known to produce desirable beneficial outcomes. So we know we have practices with proven efficacy, but up till now, they've been dependent on a somewhat fragile and fragmented system of service delivery. And at the same time, it takes way too long to get these evidence-based practices into routine care. And in that gap between evidence-based practices and the lag time from research to practice, that's where a huge opportunity lies. How can we find ways to speed up the process of translation from research to practice? And I think that gap is what is fueling the private sector, making use of evidence-based care and just building new vehicles to deliver that excellent care faster and to more people in more places. I think that's really at the heart of what digital mental health is trying to do right now. So we've seen a huge proliferation of businesses in the private sector that are building tools to help assess mental health, to diagnose, to treat conditions, to remove barriers to access, to facilitate the administration of healthcare in the mental health space. This image I'm putting in front of you, this is borrowed from the Global Institute of Mental and Behavioral Health Investment. I would say it's not a perfect map. There's some misclassifications or misattributions. I would move a few of these things around. Some of these companies span multiple areas, but the general kind of volume and the names and the companies that are out there, I think, are pretty on the mark. This is just in the mental health space alone, and this is just in the private sector. Think about the health systems and insurance companies that are also building new products from within. There's just a boom in options that are available and all of the ways we're trying to go about scaling up delivery of mental health. So with this rapid growth of companies in the private sector, the truth is, most of the key players in the digital mental health space, I believe, are working in a fairly disjointed and solitary approach. And we have a lot of groups that have a vested interest in mental health. We have academic scientists, probably a lot of people in this room this morning. We've got the private sector industry teams, like in my company, that are trying to scale services. We have payers, we have policymakers, we have health systems, we have providers, we have provider organizations, lots of different teams out there, lots of different groups. And I think one of the hard things about a virtual conference is I can't really get a sense of representation in the audience. I'd say we're probably skewed more to the academic oriented people and the private sector people. But these are all the key players that are involved in trying to create these solutions at a national level. And I think, there's so much work to be done, and yet we are all kind of just peripherally aware of what these other interested parties are doing to the left and the right of us right now. Most of our energies is focused on our own independent priorities or interests. And as a result, we're just kind of seeing a sliver of the road ahead of us, a sliver of the full picture. And I think this is why, we're not moving at a quicker pace. But there is opportunity. And I think this society in particular is one of the few organizations that exist that's trying to link these groups together, trying to bring these interested parties together to provoke discussion and to provoke collaboration. And we definitely need a lot more of that. And more importantly, we need the necessary conditions that make that interaction across these groups a must-have rather than an option or an afterthought. So this is where my sandbox analogy that I have in the title comes in. So hang on with me for a minute. I will get there. So I started my career actually wanting to be a child psychologist. And when you want to be a child psychologist, you spend a lot of time studying child developmental psychology. And we learn a lot about how children develop by examining their work, or how children play, right? That is the work of children. And there are models of play from Piaget and Parton that really help us understand that how children move through distinct stages of play and how they approach their play gives us hints about where they are with their interpersonal, social, and environmental development. And I think there's some interesting analogies that could be made with kind of what stage we're at in mental health. Right now, I think our field of digital mental health looks a lot like this beach scene. We have different kids in different areas, and we're all playing in the sand, but we're not necessarily playing together. And if I were to explain this in developmental terms, I'd say all of these interested parties working in the field of digital mental health were somewhere between the stages of parallel play and associative play. In parallel play, we each kind of have our own space in the sandbox, or part of a playground, so to speak, or part of the beach. However, we're pretty much just focused on doing our own thing and playing with what's in front of us. And we're aware of the other people to the left and the right of us, but we're not really interested in them. We're not engaging or seeking to understand what they're doing or why. We're just kind of focused on the work in front of us. In parallel play, we're really not sufficiently interested to work together or really collaborate. And I think there are probably some entities in digital mental health that are kind of stuck in that stage right now. They're probably not coming to meetings like this. They're probably not seeking these opportunities to interact with people who are not doing the same work as them. Those of us here today, I think, are probably more likely in what we would call the associative stage, in associative play. At this stage, we take an interest in the people next to us and their toys or their tools, right? We have curiosity about each other. What are they working on? What can it do? However, at this stage, we're showing interest and awareness of it, but there are limits and conditions on the ways we interact with each other. What we really want is, well, I want you to play my game, or I want to play with your toy, and vice versa, right? Not so much collaborative, but more like what's in it for me, and a little bit of self-interest is still dominant at this stage. And it's a fascinating stage because while we're more interactive, specifically that interaction is about what we think others can do for us, or what we can do for them, and what we can use that they may have, right? That's what that kind of play looks like. Why do I think we are here at this stage? Some of the clues are kind of how we see people moving across sectors. I see a lot of academics going into the private sector, leaving their section of the beach, coming to ours and working with our toys, right? And playing with our tools. I see more people coming right out of their training and jumping into our sandbox first in the private sector. And I think another sign is I'm guilty of it too. Those of us in the private sector, we're really curious about the toys you're playing with in academia, and we want to use those toys, but we want to take them and bring them over into our corner of the sandbox, right? What's lacking at this stage are mutual goals that are really inspiring us to cooperate and really play together. That true collaboration and coordination, that's the heart of cooperative play. So what would that cooperative stage look like? It really would look like us working together, bringing our best skills and strengths, and each playing a unique part to achieve some mutual goals, right? So we'd have to all want to play the same game, share our strengths, acknowledge our limitations, bring together our resources from our environments for a united effort. And how can we get to this stage of cooperation and collaboration? Well, we're not going to get to it in the next 10 minutes of my talk, but I wanted to sort of lay some foundational things where I think some essentials need to be put into place to grow into that. First, cooperative play requires communication. We need those conditions that make us talk more with each other and more frequently and have extended conversations and interactions. Right now, I think we probably interact when we want something from each other that advances our own goals. But if it doesn't really resonate or align, we maybe start a different conversation with a new, different party, right? That's more association, that's not cooperation. And I think this is a critical role that the Society for Digital Mental Health can fill. Put us in the same places where we can have prolonged, meaningful interaction, frequent communication over a period of time to help us identify mutual goals. Another necessary condition is leadership. Why? Leadership brings momentum. It acts as a catalyst. We need to identify some force of leadership that's going to help us envision this big shared goal of what we all want to achieve, and also help us see the part that we all play in it. And also we need leaders to enlist us to play those parts and lead us in an organized collective effort. We also need organization. I think it kind of goes hand in hand with leadership. You know, there is no shortage of work to be done. We all have a lot to do to move the needle on mental health, but we need additional parties to get us organized to move together. Otherwise, I think we'll probably just keep our heads down, do our own thing, and not really take advantage of a more collective power and more collective momentum. And all of us, whether we're academics, private companies, health systems, providers, we all have very specific, important roles to play, but we need something to bring us together in a more organized fashion to achieve those goals. And finally, cooperation requires peer interaction. We have to see each other as equals and not others. Okay, I'm going to say that again. We all in this room need to see each other as equals, not others. On a playground, kids gravitate towards their peers. And if you put them around kids that they don't see as similar to themselves, they revert back to more solitary activity. We want to make sure that doesn't happen, but we need to see each other as peers to facilitate that. And I'll say this much, I think mental health professionals that work in for-profit companies, we still strongly identify with the academics and people working in healthcare and the provider community as our peers, because that's where we came from, right? You made us, you helped us get to where we are. We claim you, but I'm not sure that all y'all claim us anymore when we move to industry. And I think some of this, it may be because, you know, we in industry, we understand your playground, we understand the culture, the norms, the expectations. You probably have far less visibility into the environment we're working in and who we are, what our work entails. So I think there's a lot we can be doing to try to increase that visibility and help other sectors understand us better and be more comfortable in seeing the work that we're doing over here so that you can see us as peers. So a big part of what I'm saying about this, you know, getting to this cooperative stage is having a common shared goal. And I don't think it's hard for us to think about what we all have in common that would provoke us to cooperate in a more unified way. So in no particular order, these are some of the things that I think we all care about, whether you work in academia or industry or in a healthcare setting or working on policy or a payer. These things are all critically important to the success of digital mental health. And I'm sure there's more beyond this list, but for the sake of brevity, these are the ones that I think are the big ones. I think we all understand the current constraints on providers and how that is a challenge for moving to mental health, how they're licensed, where they can practice, the rules that dictate licensure and scope of practice. And we know that contributes to the shortage of providers and the disparities in geography. And I think right now we're kind of overly relying on professional provider organizations like APA to tackle the majority of the work to shape those constraints and kind of fix those constraints to increase the volume. And I think if more entities joined in and more sectors joined in, lended their expertise, their voices, we could probably get farther faster. Reimbursement is another common challenge. We all want to get to payment models where cost-effective mental health care is adequately reimbursed. You know, there's a variety of digital mental health options out there, and there is a lot to be sorted out about what should be reimbursed, what's a fair rate, what payment models make sense, all of that. And I don't think any of us alone really realize what it's going to take to get either new reimbursement codes for digital care, to get insurance to pay for digital therapeutics, to fight for more fair reimbursement rates for providers. It's a lot. And I think I like to think maybe it's not too idealistic to think that we could probably get there faster with more coordinated efforts and more sectors involved with each other. Market acceptance is another big one. And I mean this specifically for forms of digital mental health care that are not traditional provider delivered care, provider sessions. I think there's still a great reluctance across market segments about the need and the place for digital care, digital therapeutics, digitally backed mental health services that lean on technology. And I think I have a brief but glaring example of this. You might remember when the president put out a budget proposal and there was like a lot of fanfare about improving access to mental health services. But when you looked at the proposal, what it really boiled down to was putting more therapists in places where they already exist, increasing the volume of therapists. And again, that's great, but I think, have we not forgotten that we're decades away from closing the gap on provider shortages? We cannot produce enough providers fast enough to meet that need. And I also think we might be overstating the efficacy of psychotherapy. I think maybe we've conveniently forgotten how most people drop out of therapy after one session. And at best, evidence-based therapy maybe works about 50% of the time. You know, I think we're putting a lot of energy into that conversation about providing more therapy, but we're not putting enough into conversations about other modalities and giving people other options where they can have choice in what works for them. And we really need to be getting markets more comfortable with understanding that there is a place for digitally delivered care that can be well utilized, effective, and safe. Quality standards is another thing I think we all care about. I think it's relatively less controversial for us to agree on what good quality would look like. I think we could be more explicit and have multi-sector buy-in on what it would look like to have quality standards. Some standards around shared consensus about what quality means. How do we want to define it? What sort of measurement standards should we be focusing on? And then finally, I think we all care about the well-being and stamina of the provider workforce. I think, again, it's easy to get caught up in conversations about the sheer volume of providers and how long it takes for someone to see a provider. But I think we need to come correct with how we're taking care of providers through the course of their careers. And it's such a competitive market right now for providers. And I think, honestly, our biggest competition is still out-of-pocket payers, right? Private payers, which we know is terrible for exacerbating health disparities and inequities. It's terrible from an equity perspective, and that's our biggest competition. But when you think about, what it takes to be a provider within healthcare and insurance systems and submitting claims, getting them approved, getting a fair reimbursement rate, the pressure to see more patients and get better outcomes faster, it's a crushing job at times, and it could take its toll on providers' well-being and their ability to work. And again, I think this is an area where maybe we're over-indexing on provider organizations and their advocacy arms to fight these battles for better working conditions. But the truth is we all have a vested interest in the providers out there and their well-being. So why are we not all participating to make it happen in a collaborative way? And then finally, I want to emphasize health equity. Again, I think it's a common shared goal, but I think it's more important for us to not think about it as something we should be aiming for in addition to these other objectives. It really needs to be woven into these efforts throughout all these goals, not seen as something separate or an additional objective. I think if we stay conscious of equity and we make it part of the process, part of the conversation while we're tackling these other things, we will get to more equitable outcomes. It's part of the solution for challenges with providers. It's part of the solution for expanding access. It's part of the solution for delivering quality. That's how I'd like us to think about health equity. So while this is all good to kind of lay out these big challenges on you, what would it look like for us to move forward with more cooperation? I think there's some probably early examples that we can think about where this society in particular can do effectively. One thing I think we could do that's really important is to invite more peers to the table. There's other entities that we may not normally think about that can be part of the solution. I don't know how many of you all have interacted with business groups on health. They have the ear of employers who shoulder the bulk of private commercial insurance. They have collective peer influence. They have collective buying power when it comes to what kinds of care they want for their population and who's going to provide it. Also think about organizations like the National Education Association to connect us with school settings and teachers and principals. I don't think any of us in our spaces really grasp what these other entities understand about mental health and digital care options, or what their prevailing reservations or concerns are when it comes to mental health for their populations and their settings. Another thing I think our society could do is think about crafting effective position statements for things like quality standards or provider well-being. We could take it a step further and be engaging other professional organizations to co-sign with us, right? Strength in numbers, collaborate with us on how to shape these recommendations, collaborate on how to engage policymakers to give those positions some teeth. So I think my time is up. I know I've dropped quite a lot of thoughts on you, and we can only solve so many problems in about 30 minutes, but I hope I've left you with some things to ponder about the role that you today, tomorrow, and going forward, and your institutions and organizations can play in pursuing more collaboration. And I think the reality is that us showing up here today, we're the only ones that really can make this type of cooperation happen, right? So we need to come together and think about what is our first mutual goal and just get moving. So I hope I've given you some things to reflect on. And over the next couple of days, think about the people in the Zoom room with you to the left and the right of you, and think about how can you forge some new connections, provoke some partnerships, and start working towards some common goals. And so I want to leave you with these memes. I think it was a BuzzFeed exercise where they gave kids old or ancient technology and asked for their hot takes on it. I want you to think about, what are we building? What kind of technology and digital care are we building for our next generation? And if they look back, what will they say about what we did with our technology? And hope that motivates us to be better together. And with that, I will stop. And thank you very much. And I think we're going to move to Q&A at this point.
Yeah, we will move to Q&A. So thank you, Cynthia, for a great talk, a perfect setup for the conference. And so, I guess I'll also encourage everybody to engage with each other, since, you're talking about our needing to work together and to understand each other's positions, and the way forward is really the goal of this meeting. So we have a few questions here. So I'll just go through them in order here. So the first, great presentation so far. I have a question. Academia and industry have different short-term goals. Academia is more interested in knowledge generation, whereas startups need to become profitable as soon as possible to survive. How do you propose that the two sectors collaborate given the difference in short-term goals?
Yeah, terrific.
This issue of different goals, I think, just broadly is really, would be useful to get your
Yeah, and I think, to be honest with you, I think the short-term goals, yes, could be, where the most of the pressure comes from, but I think there are some opportunities here. And this is why I think we need other people in the room to listen, because honestly, I don't know how much additional work in academia needs to be done about generating new discoveries versus finding ways to better implement what we already know is working. I think there could be more focus on implementation science, but I think we need the funders in the room to understand that and to be provoking that, because that's really where the collaboration can happen. There needs to be incentives, right, for these two parties to work together. And right now, I think we have a bit of a misalignment of incentives, and funding is a big incentive, and being able to produce more research, that's an incentive, for academia. To produce research on living products in the market, that is also a goal for industry, but we don't have great things to kind of induce us to collaborate together. And I think, more targeted funding mechanisms is one way that we could approach that.
Yeah, if I could just a quick follow on that, I think you're right, and certainly the NIMH has shifted a lot of its focus, its RFAs on implementation science, and I wonder, the short-term goals, how sort of the timelines of funding mechanisms work versus the timelines of industry, if you can speak to that a little bit, because I do think there's an opportunity, but challenges as well.
Yeah, I think one of the misconceptions about industry is that we don't care about research. I think we do, but I think the expectations for research can be a bit different in industry depending on the market. I think currently right now in mental health, a lot of the private sector industries are focused on employers and consumers who make different buying decisions than government payers and insurance companies do. And I think there's always there's these concepts of early adopters, people who are willing to take risks on less proven things. I think that always kind of carries the start of any kind of startup market, but then come after that the wave of skeptics who want to see the outcomes. So there is a bit of a runway to get research off the ground. It doesn't have to be, we're not research institutions. I think people know and understand that about private companies. There's an expectation that you get there over time, and smart companies plan for that over time and don't expect that to be their first product isn't going to be research. It's going to be, a beta version of the product, and they will eventually get to producing some evidence. But, much like in academia, we don't expect you to come right out of graduate training with a clinical trial, right? You do pilot studies, you do some observational studies. Those same kind of mechanisms also apply in industry.
Right. Here's a second question, sort of related to the first. Where's the best place to start when it comes to what the private sector needs to do to start sharing their toys in the sandbox?
Yeah, I think an easy way to start is to include more academics in industry involvement. Unfortunately, I've seen some companies that have no shred of an advisor with a scientific background, much less on their leadership board, right? I think ideally we want to see someone in leadership have a scientific background. And if not that, at least some presence on the advisory board or consultants or so. There's plenty of ways, I think, to plug in academics into the private sector. It takes a couple of things. One, it takes the companies to know they need that. I think a lot do know they need it. Some aren't as aware. It also takes that kind of, when you extend the invitation, engage in a conversation. I've had some academics I've reached out to who just never respond. I appreciate if they at least say no, but maybe like we could talk about it and could give you some ideas, or maybe I know somebody, right? That gives me something to work with. So I think involving more academics in the private sector is a way of kind of sharing knowledge and sharing some understanding and trying to figure out where is the overlap and the mutual interests and what those academics can kind of take back with them to inform the work that they're doing.
All right, we are at time, but there's one other question I want to just, because if you could just try it like 30 seconds here. So how would you hope to see training programs, master's or doctoral or internship, better preparing students to play in the sandbox?
Yeah, I have a whole other talk I could give just on
Yeah.
that. But I think that the punchline is, I don't think training programs actually have to do anything different with their curriculum and with the skills that they're giving their trainees. What I do think you need to do is think about different settings than your kind of traditional go-to settings. And there is such a thing as doing an internship in a private company. It's not as a well-worn path as it is, for most training programs right now, but I think there's a lot of companies that are receptive to it and can be creative in ways of making that happen. But it takes, that we got to get past that inertia of doing things the way we know how to do them, and take a little risk and send that email or connect with somebody at a company and see if they can make something like that happen.
Okay. All right. Well, thank you so much, Cynthia. And thank you everyone for participating here. There is a break between now and panel one, which will start at 11:55 Eastern. And if you have, and I realize there have been a few more questions coming in. So if you have other questions for Cynthia, you can join her in the Ask Me Anything session at 2 o'clock, and she will be there to continue answering your questions and to continue this discussion. So thank you so much, Cynthia.
Thank you.
Bye-bye.